Okay. So good afternoon, everyone. Dr. Abdulrahman Alqahtani, interventional cardiologist. So I'm going to share with you a case. The title is "The Gate is Breached," and the reason I chose that title is that the fact that when you look into fortresses and you feel secure, the moment you hear somebody yelling, calling "the gate is breached" is never a good thing. So hopefully I can walk you through that story back in your mind. So I had the pleasure of dealing with this lady. She's a 75 years old lady. Dyslipidemia, hypertension. She was admitted with decompensated heart failure. This is her choreangiogram. The choreangiogram was basically normal. You could see the left system completely normal, no issues. And the RCA also was normal, dominant, no issues there. We arranged for her to have an echo. An echo showed that he has a moderate LV dysfunction, 40 to 45%, with heavily calcified aortic stenosis, with a valve area of 0.7, and a mean gradient at that level of ejection fraction is about 38 millimeter mercury. So basically, she was having evidence of severe aortic stenosis. You could appreciate the LV dysfunction at certain views. You could think it's less than 40, but anyway, the calculated ejection fraction was around 40 to 45, and that's her mean gradient. So this patient at that time was discussed among our structural team because her presentation is decompensated heart failure. She has LV dysfunction and severe aortic stenosis. She needs something to be done for her aortic valve. Given her age, she was thought to be a good candidate for TAVI. She is considered, in a way, low risk if you calculated her predicted risk of mortality. Her CTA, this is the CTA, this is the annulus. So the annulus, the dimension of the annulus is 20.5 by 30 by 23, and the average is almost 21.6. And her area is 357. The LVOT is slightly larger than that, so it's okay there. Looking at the sinuses are smallish, 24.6 by 25 by 24. And the diameter of the STJ is 23 by 23 by 23 by 8. So basically smallish sinuses, smallish STJ, but the calculated area itself is not, it's about 23 for Sabian valve. So the height of the coronary, the left coronary height was 9.5, so borderline there. The right coronary height is 15.7. The angle is slightly horizontal, 57. And you could appreciate the calcification. And what you can see basically in the calcification, that the calcification mainly in the non-coronary cusp. The left coronary cusp has a speckle of calcium, and the RCA has a little bit of calcium. So we can see this patient has severe aortic stenosis. She is having LV dysfunction. Sorry, the peripherals were smallish in size, but acceptable by our standards. So given the information we have, she has a valve area of 358, so she's in a category of 23. And in terms of the coronary height, she has borderline coronary height in the left, but otherwise is okay. The sinuses are 23.5 on average, and the STJ is almost 23.5. So she's on the cusp, but there was no alarming concern. So she was accepted for procedure. It was agreed to go transfemoral, TAVI approach, 23, Sabian, S3. It's actually S3 Ultra at that time. So this is our procedure. So we aim to be slightly lower just because of that. So we went a little bit lower when we were deploying the valve, and this is where we got. And it was deployed 180, no issues after deploy right away. And then we've taken a picture right away after that. And this is what we see. Okay? So I see completely occluded coronary arteries, both of them. And if you see on the right, I've already brought a right away catheter. I went into, my pilot in a crash mode at that time. So there's a very important book. When I was starting my, as a consultant, I was given to one of my mentors. It's called Why Hospitals Should Fly. And basically, it's trying to correlate why the aviation industry is very successful in averting disaster and why we fail miserably. And the reason, because we don't have a lot of simulation. And number two, if we have an algorithm, we try to memorize those algorithms and act on it. And actually, not another person beside you go through step by step. If you watch the Sully movie where the airplane crashed in the river, the co-pilot was going through the manual and telling them every step that he has to go through if you have this emergency, and they check it together. So at that time, the moment this happened, I was telling the anesthetist, intubate the patient, and he's telling me, patient is breathing. And I was just intubate the patient. And then I activated the code. I called colleague, Dr. Saleh, who's working with me as well, came running. So I activated, and I called right away a mechanical circulatory support in the meantime. Until I get everything ready, I was trying to cross the coronaries. In the meantime, I was trying to open the left circumflex, but the left main, but that was not happening right away. CPR is running, so patient crashed right away. So CPR is running now, so we're doing that. In the meantime, we'll jump through this because we don't have time. And what I've done, I put patient on ECMO. Within 10 minutes, patient was on ECMO, and basically we have ECMO support, and then I managed to get into the left main after that. And what you can see here, look at the first pictures here. We have a left main, we have an osteal disease now at the left main, and we have an extravasation happening here. This extravasation is suggestive that you have an annular rupture. Okay, so I've taken a balloon right away, and I've basically opened the left main, and then after opening the left main, those are our next picture. So our next picture now shows us that the left main is open now, and the extravasation disappear. So did we have an annular rupture, or we did not have an annular rupture? Okay, that's something you have to keep in mind. So we waited. Echo is coming, as you can see already. TEE is there, and we're looking to see for any pericardial effusion. There is minimal pericardial effusion. But after waiting for about 1 minute, the left main itself is going back again, and it's becoming narrow. So there's something causing a compression on the left main. So we decided that now I have to stent the left main. So I stented the left main, and this is the left main after I stented. Patient is stabilizing now already. She's pulsatile on ECMO now. Okay, so we got the patient back. And then after we opened the left main, the LCX, the RCA was basically occluded. So we went after it, opened it, and this is the RCA, and we stented the RCA. And this is the final result for the RCA. Okay? And this is a final shot here. So now you could appreciate that the ventricle is contracting, the patient's still on ECMO, she has pulsatile flow, she's very stable. We don't see much of pericardial effusion, and we'll get into that. And, you know, I'm still trying to work out why this happened to start with. You know, all our metrics within reasonable measures. This is 23, it's not 26, we're within the same realms. And the things that we found, I'll come to it later, is one thing that maybe we didn't pay attention to, and this could cause this patient. So this is the echo. What I can show you on this echo, I'm not an echocardiographer, but I can explain this to you. This is the mitral valve, this is the aortic valve, this is the curtain between them. This, an echo-free space, this is not normal. This is a concealed or contained rupture. And we monitored that, and you could see it here as well. And we monitored that for a while, and the patient in the lab, you could see here, the LV function dropped significantly, but there is no significant pericardial effusion, and this is growing bigger a little bit. But, you know, it remain basically stable. There is no significant pericardial effusion. Believe it or not, we finished the procedure, patient stable. There is no pericardial drain. So we decided after that to send the patient, after stabilizing for a while, we sent the patient to the cardiovascular ICU. She was doing okay. She was having small pericardial effusion, and we did serial echoes to follow that. Later on, after 12 hours, we noticed that the effusion is actually getting bigger and bigger. Now it's reaching a tamponade state. And then we have discussion with the surgeon, and the decision was to take this patient now and explant that TAFI and fix what's going on. And this is a surgical picture. So I want to show you, this is the entry of the left main, and the laceration is just beside the left main. And you could see it bigger here. So just 2 minutes, or 1 minute actually. And you could see that laceration present there. And, you know, surgically she went well, she recovered, she went back to the ICU. 2 days later, we were trying to inhale her for ECMO, she had significant GI bleed, and that's just led to further demise, and eventually she expired on the 3rd days, not from the TAVI itself, but from the consequences of the ECMO-related bleeding that she had. And she had major bleeding in her abdomen, and the surgeon did not feel that she was fit to intervene on her at that time. So she did expire. But the thing when we went back, what we didn't realize is the height of the STJ in relation to the annulus itself, it was about 12 millimeter. And if I go back, do we have the image? Just, can we have the slide for 1 second? Does somebody here at the back? Okay, thank you. So I just want to show you these pictures here. Where is it? Yeah, this one. So if you look here, you see this crown here is almost protruding. So the crown here is almost protruding at the STJ joint. So the height of the STJ joint was not really big enough to accommodate this valve, or the valve should have been lower. Also, given the narrow sinuses, it was not helping. What else could be done if we use self-expanding? Maybe it may be different, but again, the sinuses was not generous enough to give you that. The STJ was going to possibly leave that. The height of the leaflet itself was almost at 11. So those are all factors that to look at. So anyway, this is just a dreadful complication that you don't anticipate, but if you face it, you have to handle it in a systematic way. You cannot fluster. You have to be systematic in the way you approach it. You call on help. You put patient on mechanical support, and then try to restore flow, and then deal with that afterwards. Those are the things I wanted to say. There was one paper I wanted to show just published recently, which is basically talking about those new variant, the height of the STG joint or the cusp height in relation to the left main. So if it's higher, then this is high risk. Again, the simulated or the simulated valve space, like distance to the coronary sinus, it's similar. If it's less than 4 millimeter, it's an issue. And the last thing, if you have a leaflet calcium more than 600, single leaflet calcium more than 600, then this is another risk factor they have to take care of.
Great, Dr. Rahman. So you took us through the battle, and you told us the lesson you learned from that battle, breached, and so how we reinforce, how we tackle that in future. So I think we need to move. Thank you very much.